Okay, I'll start off today's series of talks on how to actually use this set of guidelines. And with that, I'll go through some of the background to how this guideline came about, what we go through, what the constraints that we face in drafting the guidelines, and possibly in how you're going to use it in your day-to-day practice. So what are guidelines? It's an indication of a course to be followed, and these are statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. And the U.S. Institute of Medicine says that these are systematically developed statements to assist practitioners and patient decisions about appropriateness of healthcare for specific clinical circumstances. While we embrace this definition, on the practical aspect, in the Singapore context, for guideline development, we follow the Scottish, what is it called now? The Scottish Intercollegiate Guideline Network protocol as how to develop these guidelines. So last night I was at a function, and a prominent prosthodontist came to me and said, your categorization of your levels of evidence is not quite right. You got this as 1 and that as 2 plus. Well, there are subtle differences between different organizations as to what they classify as level 1, 2, 3, 4, and then there's 1 plus, 2 plus, and 2 plus plus and stuff like that. But the differences are largely subtle, all right? So if you follow the American style, the Cochrane collaborations grading, they have one set of grading, and even within the UK system, if we follow the sign, but if you happen to look at the NICE guidelines, then there are again subtle differences. So you don't have to look into the detailed part about whether this particular paper, did we grade it as level 1 plus or level 1 plus plus. I think if you overall, you look at it from the perspective of a level 1 is definitely better than a level 2 and better than a level 3 and so on and so forth, right? They are not clinical protocols, so they are not a cookbook whereby it doesn't mean that we create this set of guidelines and then practitioners can just take this cookbook and say, okay, from step 1 to step 2, if I want to do this particular procedure, I just follow this and I'll be fine. All right. At the end of the day, the individual practitioner will still need to exercise his own professional judgment based on the signs and symptoms of the patient. You got to assess the patient and you make a judgment yourself. And what we have done here in the form of the guideline is to provide you with evidence-based recommendations. As to whether that particular recommendation is suitable for your patient in that particular instance is entirely up to you, right? So the ultimate judgment regarding a particular clinical procedure or treatment plan must be made by the appropriate healthcare professional in the light of the clinical data presented by the patient and the diagnostic and treatment options available, right? So this summarizes what I said earlier on, because while we may make certain statements in the guideline, if you happen to be in an environment where a certain technology is not available, then obviously you cannot offer that kind of treatment option, right? So it's based on the circumstances itself that you make the appropriate decision for the patient. But having said that, you can use alternatives to whatever is written in the guideline, but the alternatives should be able to withstand a fair amount of scientific rigor. And this is the entire trend of where clinical practice is headed towards. Now, this is not to say that everything that we do must be evidence-based. There's a lot of things that we do that is just not evidence-based. And some things don't need to be evidence-based. For example, the commonly cited analogy is that how do you test whether parachutes work? Do you do a randomized control study, like let's say I take half of this room, I put you on a plane and I don't give you a parachute, and the other half I give a parachute. You get up on the plane, you get a certain height, everybody jump off, then you count how many people survive and how many people did not survive. So some things are just common sense, right? But this doesn't mean that any parachute works. So the evidence-based part comes in when maybe brand A parachute or parachute design in a certain way works better than parachute design in a different way. And these are things that we do need randomized controlled trial to make a value judgment or considered judgment as to which design of parachute is better for us. The different types of guidelines that can be developed, ranging from expert opinion, and this. Why is there an advertisement here? Ira? No, there's something on the screen here. Never mind. The guidelines reflect, if it's expert opinion, guidelines reflects the views of opinion leaders, specialist societies. So very often you can have, say, a specialist society, say SDA coming up with a position paper, and it may be just a gathering of people who are rightly recognized as experts in the field, and they, with their collective wisdom, come together and make a statement. So this is the traditionally in the old days, before the advent of evidence-based philosophies, that is how guidelines are developed. It's the three wise men approach. You get enough wise people together, and hopefully what they say would make sense, right? It's an inexpensive way of doing things, because usually these wise men will volunteer their time. They just need to sit together for an afternoon or so to share their opinion. And in the past, we do have a lot of, like, even for the implants, a lot of consensus conferences. These are basically three wise men or more, maybe 100 wise men in the room deciding or discussing something, and then when they come together and they agree, and that forms a statement. But this has a high potential for bias, because sometimes birds of a feather flock together, right? So if we all practice in a certain way and we are recognized as experts in certain areas, maybe it's because we are doing things similarly, and then when we come together, we differ very much in terms of what we say, and that becomes a highly biased statement. And then, of course, there is this issue of conflict of interest, because as you become an expert in a certain field, maybe the manufacturers of those products that you use may tend to use you as an opinion leader or something like that. And then if you get paid for it, then there is a conflict of interest. As happened with certain technology, which is very commonly used by a lot of oral maxillofacial surgeons. For example, the issue of using hyperbaric oxygen therapy for patients with osteoradial necrosis of the jaws. So it's a protocol that's been used widely by a lot of centers, and then later on they found that the very first paper, or the authoritative paper that's written by a certain person on this technique, actually has a vested interest in a company that manufactures hyperbaric oxygen chambers. So that throws a lot of doubt into the credibility of that kind of that paper, notwithstanding the fact that there are a certain number of patients who have benefited from it. All right. So in modern times, guideline development got to be more evidence-based than that, and we got to have checks and balances in place. All right. So yeah, this is the other form of the three wise men, a formal consensus, where, like I mentioned earlier on, the consensus conference that people have. So what we do now is evidence-based guidelines. It's a systematically developed statements to help professionals assimilate and evaluate the ever-increasing amount of information on best practice. And so they're less susceptible to bias in the conclusions and recommendations. When we formulated the committee, we took great pains to ensure that there's a fair representation of people from different specialties and different background, be it in private practice, group practice, a solo practice, in institutional practice, and different specialties. And I've been largely responsible for picking the work group members, and I intentionally picked some people who are well known to be a bit more controversial. And it's good to have controversial views, and our committee meetings sometimes can be quite exciting, to say the least.